Okay, I think it's recording. Maybe. Anyway. So basically, the good news is it's really late and I'm going to be hungry soon. So this is going to be, a little short. Because in about 30 minutes, I'm going to need to go get something to eat. But standard 4 is really important. And so probably what's going to happen is I'm going to do this recording, hopefully not for very long. We'll see what I get through, and then I might have to finish it up in another one. Because I want to give you guys some background, and this is also where we talk a little bit about HIPAA. And so I just want you guys to kind of be aware of some of the issues that go with HIPAA. I can tell you that every time I sort of review HIPAA as a thing, it's a lot of rules, but for the most part, before it came in to law, there was a lot of like, oh my God, we need to learn this stuff, and every continuing education thing was about it. My take was that as long as we stick with the APA ethical code, we're really probably pretty good in terms of HIPAA and how to stay compliant with that. That being said, there's some sort of specifics about it that I need to explain as best I can, because there's a little bit of it that gets a little confusing. For example, the difference between a therapy note and a progress note. So, yeah, I'm gonna see what I can do with that. I went down a rabbit hole, so I figured might as well take you with me. All right, so we're going to talk a little bit about standard 4, and I'm hoping I can also, as part of this, answer your Q&A questions. But with standard 4, 4 is basically all about privacy and confidentiality. And it's not just confidentiality with therapy, even though that's really important. It is confidentiality that applies to research and also student records. There's actually some federal laws about that as well. So make sure I remember how to do this. Oh, I got fancy. All right, so basically, I never use the transitions. There's a difference between privilege and confidential information, right? So basically, that idea that we are supposed to keep some information confidential is really just sort of an ethical code kind of thing. This is what we are supposed to do. However, privilege means that basically there are legal ramifications and laws that mandate we protect certain types of information. So the court ruling that basically gave psychologists privilege and other mental health professionals was Jaffe v. Redmond in 1996. So basically, and you guys can read this, but essentially, because of the sensitive nature of the problems for which individuals consult psychotherapists, disclosure of confidential communications made during counseling sessions may cause embarrassment or disgrace. For this reason, the mere possibility of disclosure may impede development of the confidential relationship necessary for successful treatment. What Jaffe v. Redmond did was basically establish that therapists have privilege at the federal level in federal lawsuits. Somebody asked once, or maybe I went down the rabbit hole of what if it's a state lawsuit? Yeah, I'm just going to go with Jaffe v. Redmond gave us the right to privilege, and if I ever actually get subpoenaed, I'm calling a lawyer and phoning a friend. So, in general, standard 4.01 is that we are supposed to maintain confidentiality. And if you notice, part of this is that we have a primary obligation and take reasonable precautions. So one of the things you guys were asking a lot of questions about was basically that, what happens if you make a mistake and then are you going to get in trouble? No. As long as you didn't deliberately do something, if it wasn't willfully ignorant, if it truly was just, oh gosh, something happened and I had done everything and this still happened, you just have to take reasonable steps to correct it. But we do have to try to anticipate when those things might happen, and so that we protect our patients. Also, guys, I want to tell you, these are copyright 2006. I swear to God, I took them out of like a 2022 book, but I'm kind of embarrassed by that, and I have added information, but here we go. I tried to update to the new ones. They kind of sucked. So a couple things to keep as sort of in mind is that, when in the old days, there was some concern about using cordless phones. Like if we actually had a crisis call and we're talking to our patients, one of the problems with the old cordless phones, those original ones that came out, I actually still have a landline over here. The frequencies were the same as like baby monitors. And so you would be like talking and somebody 3 doors down was actually listening to your conversation on the baby monitor. That can be a problem. Now we have to worry about internet, cell phones, and all that sort of stuff. So in general, you need to keep in mind that when we're doing anything internet related, honestly, if you're using like a computer system to archive or store past files, like you decide to scan them so that you don't have a bunch of paper floating around, then you need to basically not have that computer attached to the internet. I wouldn't trust records to cloud storage or anything like that. You need to do things like encrypting that information and keeping it safe. Otherwise, you're just, a big ass data hack and you've got your personal records or your patient's records all over the place. So use encrypted data transmission, password protect data storage, make sure you have adequate firewalls. My best advice, don't have that computer hooked up to the internet. That's just going to keep you the safest of all. That being said, being able to scan things means that practices don't have to rent storage units now and rotate the paper every 7 years. The standard kind of seems to be that you're supposed to keep it for at least 7 years past discharge. If you have an active client like I do with Karma that I've been seeing for a very long time, I have every one of the pieces of paper that I've ever written on. So it is once the client you've closed the case, 7 years, then you can actually destroy or shred the records. These days, though, given our capability to scan, there are some people who suggest maybe it'd be safer to actually keep them. Just keep them safe. In research, we have to keep and protect confidentiality of our research participants. Later on, there's a slide. Or wait, no, it's here. Sorry, I looked through this stuff. But you also have to anticipate things like if you're working with a small niche group, like if I wanted to survey international students, I know Claudia and I had talked about that, and Ellie and I also had talked about it. If we decided to do a poster and talk about Nepalese students from Nepal. I guess it'd be Nepalese. That sounds weird. That's only a few students. And so if you have information that might not seem like it's identifying, that's a very small, close-knit community. And if someone walks by that poster who knows that community, they might identify that person. So keep in mind, there are things that can happen that will identify someone that we might not think through. So the best idea is to always use a code, keep the code and the identifier separate if you actually need to know who this person is, and make sure your stuff is truly anonymous and not just because you're asking for a name. There are other ways to identify people. Typically, the minimum is to have a separate consent form that is coded so that you can keep that away from, if you actually have to have them sign their name, you keep that away from the actual data. So, I can go off on that. In therapy, you have to think about how you store your records. We already mentioned that. And basically, this is the federal law that establishes the right to privacy for college students. Basically, I cannot release any sort of student education records without their express written consent. When we were dealing with COVID and people were recording, there was a lot of discussion about, for example, if I record a lecture, it is okay to then distribute that to students within the lecture, but it would not be okay for me to then use it again in another class. The idea is that in the class, you've given express commit, you have basically expressed consent within that class. That right to privacy is kind of gone. But if I have like a question and answer session like we do in our classes, me just having that recording and referring to Taylor as Taylor, for example, like I did the other day, is breaking her confidentiality. So I couldn't use that recording in a future class. I couldn't do it if there was any way that your voice might be recognizable. If you had potential students in the shot, all of that we can't do. Or if I wanted to, I'd have to get everyone in the classroom's permission to then use it the next time I teach the class. So The university website has a lot of information about FERPA, and I'm going to kind of leave that there, but even our educational records you have to respect that person's privacy. Taylor, I'm not sure, I'm sorry, anticipating, not to call you out, but those of you who are working with kids or who are thinking about working within the school system, I honestly don't know. I don't know how this applies. With the college age, it's easy because technically they're adults, they're 18. I don't know how it would apply to kids. I've never looked to see what happens in the school system, although I have a feeling kind of all bets are off because of, basically the adult has the right to consent and things like that, the parents. So this one's kind of important, and I've talked about this before. Psychologists, and there's some later slides, but basically we really need to do this at the outset of therapy. So I think I've mentioned I actually have a form that I have my patients sign before they even walk back into the office with me and I start talking to them. But basically we talk about those limits to confidentiality, as well as, and if you're working for an organization, it's where you explain, hey, this is what happens with this as an organization and how the information is going to be used. You talk about how the information might be used in the future if there's any sort of reason to do that. And the ones in case you guys don't remember, the ones we have to basically make sure they understand are, that if there is suspected child abuse or neglect, or abuse or neglect of the elderly, or someone who is disabled, so think someone who is has an intellectual disability, we suspect that we have to file the report to the appropriate agencies. Suicidal or homicidal intent, we've talked about that a little bit, and remember that means that basically that your assessment is that this person is at imminent danger to do these things. With homicide, in case I don't get to talk about this later, with homicide there has to be an identifiable victim, which then gets into a whole bunch of gray areas, because what if they say them all? The subpoena part we talked about. At the end of the day, if a judge subpoenas your records, you have to turn them over. I think, that's where state law comes in versus federal law, but technically you can argue privilege. You can also, for example, ask to send a summary report rather than the full record, and things like that. We also have to explain to patients that we're going to submit information to their insurance. If they plan to file insurance, there's certain information we have to give to their health plan in order for them to pay. It's minimal, but it's still some information. Primarily it centers around that diagnostic code or the plan for treatment. Okay, so HIPAA, we all have to, even a private practice, you have to still follow HIPAA even though you're not a medical doctor. We have to basically give them a lot of forms and explain what HIPAA is. Later in the slides, I have some, I think I have them on Canvas, some links if you want to go look at HIPAA. I actually had a hard time finding the full body of HIPAA. It's much easier to find little summary statements and things like that. It had been on the government website. I think it was the CDC or DHS website. I haven't looked since the beginning of January, so God knows what's on there now. But basically, one of the things that you have to do at your practice is there has to be an identified privacy officer whose job it is to make sure that the clinic is following HIPAA rules and the appropriate things that are supposed to be sort of posted as notices are there and things like that. A lot of it, honestly, you're signing saying you understand that the doctors might talk to each other about things and they're still going to do grand rounds, but you're giving them permission to go ahead and do that. It does also, though, establish that thing I mentioned before. The information is the patient's. This is usually how I explain it to them, but the paper is mine. So basically, the paper it's written on. So I can't destroy that information if the patient doesn't like it. I don't have to delete something they don't like, but I do have to share that information with them if they request it. So, yeah, I'm not sure why that one's in there or why the Affordable Care Act, we follow the same rules. So, outside of therapy, very important. There are some circumstances where maybe that won't happen, but I can't think of many except for like a true emergency where I kind of have to dive in and act quickly. And then we also, if we're going to use any sort of electronic transmission of records, which would include things like billing online or faxing, then you have to explain that and explain to the patient the risk of the limits of confidentiality. Billing tends to be in a secure server environment, although I will tell you guys one of the worst leaks of my information, other than the Equifax, which is you have to get like an Equifax report if you're getting a big loan, so they got everything. But before the Equifax, it was a Blue Cross a breach. But what they stole basically was me as a provider, my social security number, and all those things. My best advice is just freeze your credit. Just freeze it. Don't risk things. All right, so recording. You can technically record, but you have to get a special separate consent to do that. Then you should also probably explain how you're going to store the materials for how long and things like that. Opens up a lot of stuff, but you know, I used to, when I was in training, on internship, I would have to record the session for my supervisor to review. That's the only time I've ever done this. So there's that. Yeah, this one, just remember, like, you only put information when we write a report, when we send information, we only put in it what's relevant. You don't need to put random things in there. And also remember, we always hedge with allege, patient stated, my impression is, we don't know anything for a fact. So, yeah, we only talk about confidential information with people who need to know that confidential information. So, there is a caveat. I don't know if it's in here or if I'm going to skip over it. I can, when I tell you guys sort of stories about and use in a real world example, most of the time in like psychopathology or abnormal, I change details or I merge people together to make a really good example. But I have to change details and make sure that I'm protecting that person's privacy, and not include anything that can be identifiable. So basically we have to be careful about that. And in order to disclose information, even to file for payment, the patient has to give you consent. So that's kind of part of that packet they usually sign when they first come into the treatment or to a treatment setting. So like they get this packet of information. There's some measures I have them fill out. Like I always give a Beck depression inventory because it's important to know. Plus it has a question about suicide, which kind of alerts me, do I need to do a deeper dive than just ask? Sometimes people will write things down that they won't tell you. So, but it's in that packet that they sign. Again, before I even bring them back, they have to sign all that stuff that they understand, like how the information is going to be used, how we're going to send the information for billing and things like that. Okay, so this is some more stuff about HIPAA, and I decided to kind of go through this fairly quickly. HIPAA requires that covered entities obtain written valid authorization from the individual or his or her personal representative prior to releasing what PHI is personal health information. So it just establishes you have to have consent, which we already had in our ethics code. You have to, you basically are supposed to agree to a reasonable request, but you can deny a request only if it is reasonably likely to be associated with harm. And sometimes, people don't sign a consent form just for what you're going to discuss that day. So let's say I have a patient who has signed a consent form and they have given me permission to release information to their husband or their parents. And the parents show up one day demanding to see information in the chart that I know would send them into orbit and potentially lead to a messy, if not possibly violent sort of thing, then I can withhold that information. So that's not a great example, but that's the best one I can come up with. Under HIPAA with research, private health information created or obtained during treatment research may be suspended temporarily for as long as the research is in progress, provided the individual has agreed. So that goes into your research consent. In treatment studies, you have to send certain pieces of information to a lot of different people, including there's people entering data, there's lots of people taking information, and you have to then basically send it to the site that is going to actually put it all together and do data analysis if you're in one of those multi-site kind of studies. So, but again, that goes into a research consent form, what's going to happen to the information related to side effects, your reaction to the medication. That's technically PHI, but in a research project, we kind of have to, you have to share that in order to be able to use the data. All right, psychotherapy are what they call process notes. Under HIPAA, patients do not have the right to access psychotherapy notes, and a client patient must provide a separate signed authorization specific to the release of psychotherapy notes when a covered entity agrees to their release. Okay, so this is going to start, and I think I have a thing a little bit later where there's this deep dive on what is a process note or psychotherapy note versus what is a progress note. Of course, they can't pick, terms that are close. They have to do, you can't pick separate things. So there is this, and I went down a deep dive, and I don't think I posted this stuff, but basically like a therapy note versus a progress note, or a therapy note versus the medical record. So I tried to find something kind of cogent and straightforward about how to explain this. So this is what I found, and like I said, again, this is one of those things that everybody acts like everybody's supposed to know what it means, and you don't find a lot of clear definitions. So one resource I found, great, I don't even remember where I got this. So basically, therapy notes are the clinician's private record of their patient encounters, or called psychotherapy notes. Basically, this is where you track what happened at each appointment, but the idea is that this is where you might write down your thoughts, your impressions, your feelings about the conversation. It might be, for example, if a patient brings thought monitoring in and we go over it, this is where I store it for, have it for in that file for a couple of weeks to make sure we're not going to come back to it. But it is more like where I might write my personal musings. Typically, if I have something that I would call process or psychotherapy notes, it is things like the patient's homework and what we discussed, and sort of my ideas about what do I need to remember to do next time, things like that. So with that therapy note, they usually have sensitive information out of context that might not be understandable, and they are kept confidential. So you basically, this is not stuff that's in the official medical record, and it doesn't have to be turned over or released in terms of that personal health information. This was from, what was it called? Capsules. It was another kind of helpful, this was actually a pharmacy website where they were talking about what is the difference. So psychotherapy notes are granted special protection. According to this, HIPAA defines these as recorded by a healthcare provider who is a mental health professional documenting or analyzing, that's the key part there, the contents of conversation during a private counseling session, group, joint, or family counseling session. They are maintained separate from the medical record, which is where you do have to release the information, actually separate and in a different location. Don't have them in the same medical chart. Don't make them different colors. It needs to be in a separate file. So it's very clear that this is sort of sensitive information. Now, this is not where I would formally document things like whether this client was having suicidal ideation. That needs to actually go in the medical record. This is more just me randomly thinking, or like I said, those homeworks where if a lawyer got a hold of them, it wasn't going to make a lot of sense. It could be potentially damaging, and it is not cogent to any sort of legal sort of thing. This is literally where the patient is like sort of writing down how they think and how they feel, which could be very embarrassing, and like I said, in the wrong hands could absolutely be taken out of context. So, it is maintained separate. A psychotherapy note does not contain medication, prescription, and monitoring. That goes in the official medical record, or I don't want to screw up the terms, the actual progress note. So medication and how they're in monitoring, how long the encounter was. So we always put like, met with a patient for 60 minutes. That goes in the official medical record, or basically progress note. I want to make sure I'm getting all this right, because like I said, the terms get so damn confusing, and I wish they would basically like not do that. Anyway, I like medical record versus progress notes better, or psychotherapy notes. But progress note and medical record is used interchangeably because they don't really think we have a medical record. So medication monitoring or prescription, like no record of the prescription or medication monitoring. Duration of the encounter has to go into the official medical record, or progress note. The modalities and frequencies of treatment furnished. So basically, if I write something like engaged in, referenting with the patient regarding this issue, reviewed their thought monitoring, and helped them develop appropriate challenges, that's the medical record. So that you basically have to release. The content of the thought monitoring is where I put in those psychotherapy notes. So progress note, medical record has what we did, what the therapy was, what the outcome was, but it's not that kind of detailed. Here's what they reported. Here's what they were thinking. Oh my God, can you believe this? Results of clinical testing has to go into the official medical record, or progress note, and a summary of the diagnosis, functional status, and treatment plan, symptoms, prognosis, and progress is all official medical record. It is the person's private health information, but it has to be an official medical record. So hopefully that wasn't terribly confusing, and it made a little bit of sense. But basically, think of like the psychotherapy notes are kind of like our therapy notes, or what they call sort of your personal thoughts about it. The medical record or progress note is where the official health information goes, and you do have to release that upon the client's request. So let's see if there's anything else in this one. Yeah, this one just says like therapy notes are private records meant to help the therapist remember patient encounters, so it jogs your memory for the next time, whereas a progress note records information relevant to the patient's treatment and response to treatment. It covers such information as diagnosis, symptoms, medical history, test results, treatment plan, progress of appointments, prescription medications, etc. Not that that would be confusing at all. All right. Yeah, let's see. Without the consent, only as mandated by law or where permitted. Like basically, if there's an emergency, you might want to consider what to do. Basically, you can obtain consultations. Technically, the safest thing, guys, is to basically just get consent. And if you don't have consent, then don't give the person you're consulting their name. Protect their information. I can, though, release it if it's to protect me or someone else from harm. And basically, we can, for example, turn over the fact this person has a balance to like a billing company, but you only give them minimum information, just that they owe me this much money, and it's a collection agency basically. So yeah, and I think the provide needed professional services is when you're talking about like that organizational thing, or like within a hospital setting. Yeah, but basically, for the most part, it's just safest to get that consent. We're almost at 30 minutes. All right, but let me tell you a little bit about Tarasoff. The duty to protect laws, or what we call the Tarasoff laws, basically are that when we have to basically contact someone and let them know that they, basically if someone is expressing an imminent intent to harm another and like homicidal intent, like slap somebody around, it's bad. You should do something, but it's not this. Basically, we have to do everything. We have to keep that other person safe, and that means we do everything we can to keep the intended victim safe, up to and including notifying the victim. Most state law, like Louisiana state law, doesn't say we have to notify them, but we have to take action to keep them safe. So, for example, I could involuntarily admit the person for treatment, the person who's threatening to harm, in order to keep that person safe. And like I said, one of the things, guys, like when you get the nutshell of Tarasoff, I don't have time to go through the whole thing. What I can tell you is that, though, it's not like the person, the therapist at the university was just grossly negligent. He actually called the police. The problem is police can't do anything if someone's just thinking about harming someone. They didn't tell the intended victim because she was away from campus on break and wasn't expected back for several weeks. So, they had done up to, like, I don't remember if they tried to hospitalize the person, but it wasn't like they just ignored it. The problem was that the intended victim returned earlier than they anticipated from her trip, her like semester break. She had gone to visit her family. She came back early. And so the family sued because they argued that there was one more step they could have taken. They could have notified her. And if they had, then she would not have returned to campus. And the jury agreed. And so that's why we have those Tarasoff laws. I have to disclose, as I said before, with suicidal intent. And basically, with research, make sure that you stay up to date on the laws, because there are some laws about things like passing HIV on to a partner without telling them that you have been exposed. So basically, you need to stay up to date on those. All right, so, wait, one more. Some states also have some rules about violence and school violence, and when you have to take action and report, so you need to be up to date on those. Basically, some therapeutic, essentially, it gets wonky, and so my best advice is you have to respond to the subpoena. You're only supposed to give that, quote, privileged communication with authorization. At the end of the day, you probably, if they give you a court order, then you have to do that. If they say you must, so the subpoena isn't enough. The judge actually has to say you have to turn over the records. But consult a lawyer and also try to work with them so that you're not releasing anything that's really privileged. It's more of a summary. And I usually, the first thing I do, I would contact a patient and tell them, hey, here's what's going on. Do I have consent to release? If not, then this is what I'm going to have to do. But you should probably talk to a lawyer as well. Yeah, we're going to leave that alone. Already said that. Again, there's state laws like that now impact mental health. And I'm pushing through because I think I'm almost finished. So if I can finish this, then I'll do a short one with the Q&A stuff. But basically, some states that there are some states that have, what was it, red flag laws, basically that if someone is in a mental health crisis, the therapist can notify the appropriate legal professional, like the sheriff, police, and they can actually remove the weapons from the home. Very controversial, and also be very careful. It's not, that's the sort of thing, you're taking away somebody's liberties, and you never want to do that unless you're sure that this is something you need to do. When you phone a friend, you don't release the name or any other identifying information. It's more like, hey, I have a client, here's what's going on, help. And again, you only release the information necessary for the consultation. So I don't give them a whole backstory. Oh my God, you won't believe what she did 3 weeks ago. It is literally just a, here's what I need to convey to get your opinion and move forward. Oh, so this one, teaching. I can actually use confidential information, but this is when you basically make sure that you protect those people. You disguise them. I do my whole thing about it would be really inappropriate for me to release information and go from there. Had a patient once who means I'm talking about several, and making up some stuff and using some examples that I was told when I was in your shoes. Some links to HIPAA if you want to go look. I did find those before, and I think I had updated some stuff. And we already talked about the psychotherapy notes, so I'm not going to go through that again. Haha, yay! All right, so I'm going to do another one answering your questions. It should be short. Thanks very much. See you guys in class hopefully real soon.